Neuropathic pain is caused by nerve injury or dysfunction of the sensory nerves in the central or peripheral nervous system. There are numerous types of neuropathic pain, most of which are complex and frequently chronic in nature. Pain may be generated in the central nervous system, such as phantom pain from a missing limb or tooth, or it may occur because of what is referred to as peripherally generated polyneuropathy, as seen in diabetes. Mononeuropathy is usually associated with a single nerve injury or compression, which is seen in trigeminal neuralgia, carpal tunnel syndrome, and postherpetic neuralgia. Psychogenic pain is physical pain caused, increased, or prolonged by mental, emotional, or behavioral factors. It's a very real pain, and we run into this type of pain a lot in dentistry. Diagnosed after all other causes have been ruled out, it frequently manifests as headaches, stomach aches, chest pains, or muscle discomfort. Individuals with depressive or anxiety disorders may experience complications with any type of pain. The pain is typically more intense and lasts longer than usual. It can be multidimensional and require more than one treatment modality, such as psychotherapy, biofeedback, hypnosis, antidepressants, or non-narcotic analgesics. The brain can actually manufacture pain. For instance, someone who's detoxifying from pain medication after an accident. Patients with pain disorders may respond differently to dental pain. Because of the subjectivity of pain and the stress it puts on a patient's cognitive function to provide an accurate assessment, pain intensity rating scales have been developed. This helps patients to communicate better the degree of pain they're actually experiencing. They work for any age. Here is 3 examples of pain scales. The first is a Wong-Baker FACES pain rating scale. It's very simple, numeric from 0 to 5, and it goes from a very happy face to a crying face. The descriptive pain intensity scale is descriptive as to how the pain feels. It either goes from none to the worst pain possible that they could imagine. The numeric pain scale goes from 0 to 10, where 0 is no pain at all and 10 would be the worst pain possibly imagined. The majority of patients willingly schedule and show up for dental appointments. Their previous appointments have been positive experiences, so they come back. Some people avoid dental treatment just because of the local anesthetic. Others have had very traumatic experiences and are scared to death to varying degrees. In other words, people's fears can override their understanding of the need for their dental care. As long as nothing is hurting them, they're not going to come in. So for those that do come in, we need to assess them for their level of anxiety, and this can start from the very first phone call to make an appointment, walk in the office, or sit in the chair. Standard protocol for identifying anxious or fearful patients will begin by asking about their previous dental experiences. Be attentive to their responses and caring with your tone of voice and your level of interest. Ask open-ended questions so that they have a chance to elaborate. Ask further questions if they show indications of problems or issues, such as, do you have any concerns about your treatment today? Or what kind of difficulties have you had in the past? Assure patients that difficulties that they have experienced in the past can be managed and overcome. With today's modern methods, there's no reason that they should feel uncomfortable. Involve the patient in identifying strategies to help manage their fears. Give them choices: nitrous oxide, topical anesthetic, or local anesthetic. Box 2.2 of your TAC shows an example of how you might minimize patients' anxiety and fear. Prepare by utilizing relaxation techniques such as focused breathing, distractions such as music or visualization, and muscle relaxation. Background music, headphones, a blanket if they're cold, dim lights, or aromatherapy can help. Rehearse procedures, allowing patients to practice control and self-calming techniques. empower patients with strategies that give them control during their procedure, such as raising their hand to ask the clinician to stop. Praise patients for using specific coping techniques that are helpful to them. Debrief by discussing with the patients which aspect of the treatment went well and which did not go so well, and then discuss what can be done at the next appointment and how you can modify those strategies so that they'll be even more comfortable. Involve the patient in identifying what would be best for them. This gives them a sense of control and a sense that you truly care about them. Non-invasive and non-pharmaceutical methods for managing pain and anxiety can be using words and actions that facilitate a trusting and caring relationship and instill a positive rapport. Use friendly verbiage and nonverbal communication. Show a positive attitude. Begin with a welcoming smile and a genuine display of sincere kindness and concern. Keep your language and actions calm, slow, relaxing, and gentle. Review treatment plans, addressing any of their fears, including the fears of the unexpected and of the loss of control. Obtain informed consent before beginning any treatment. Other non-invasive and non-pharmaceutical strategies can include hypnosis. Growing evidence is suggesting a strong link between hypnosis and the physiology of pain for effective management of pain and anxiety. When in a hypnotic state, patients can feel calm and relaxed. By concentrating intensely on specific thoughts or memories, they're able to block out distractions and manage their thought patterns. These thoughts and images can create for them a sense of comfort and pleasure that helps reduce their fear and anxiety. Brain scans have confirmed a disconnect between the part of the brain that is registering the pain and the anterior cingulate cortex, which is responsible for attention. So basically, they purposefully aren't paying attention to it. Even though the formal practice of hypnosis requires specific training, a clinician can use suggestive words to help calm and relax patients and focus their attention on other things. In severe cases, patients can be referred to qualified hypnotherapists. Systematic desensitization, such as relaxation therapy, biofeedback, other coping strategies, usually require the assistance of a specialized professional. But distraction, such as calming music, TV, aromatherapy, decorative ceiling panels, even a paraffin dip can help distract the patient from the negative stimuli of the appointment. The next level is the invasive pharmacologic approach to sedation. For the conscious patient, of course, you're going to have local anesthetic. Eliminating the pain associated with dental procedures through the administration of local anesthetics can significantly reduce patients' fear and anxiety, but the knowledge of getting the injection itself is another whole source of fear and anxiety that you have to deal with. Oral medications such as Valium or Halcyon are given prior to appointments for the purpose of relaxing anxious patients without producing unconsciousness. They take about 30 minutes to work and they peak after about an hour. They need someone to take them home at the end of the appointment though. Titration of nitrous oxide is rather difficult with these patients because of their altered perceptions. So it's difficult to determine just what the right level of nitrous oxide is for them. Inhaled agents such as nitrous oxide has many advantages and few disadvantages. The effect is rapid, the titration is effective and accurate, and the elimination is rapid and complete. For an unconscious patient, obviously it would be general anesthesia. It's been used ever since the days ether was used. It's usually done at hospitals with specialists, but sometimes usually on that pedo patient or the severely anxious patient to where all other conscious in-office strategies are ineffective. They might actually need to be scheduled at a hospital to be put under general anesthesia to have their dental work completed.